All right, so hi, good morning, everyone. Okay, so I'll just wait for a while for more people to join, and then we can start our session 3 of the pyqs of all the fmge examinations. And good morning, taking baby steps. Okay, good. All right, good morning, Ganesh, Anuradha. All right, okay, so just give me a moment. I'll just adjust my mobile device so that you all can see the questions and you can easily enjoy this session. So meanwhile you guys join, just give me a moment to adjust this. Okay, so I hope that your studies are going fine, everybody's preparing well. Okay, and so this is the session 3rd, okay, now for your exam. And just have a look if you are all right. So how is this? Let's make the settings a little better. Is this fine with everyone? I hope you all can see the MCQs here. You all can see the screen properly. I think that should be good enough. All right, so this is fine, no? Everyone, if you can just let me know if the screen is visible, will the question be okay for you? All right, yes, fine. So bachon, now this is your 3rd day. Okay, this is the day 3 basically of your pyqs, right? And in the past 2 sessions we have done basically the two I think 3 or 4 sessions of your fmge exam has been taken up. So now I have some more papers coming from last 4 or 5 years. Maybe after 2021 we have the papers. So 2020 was the year when the trend actually started changing, right? 2019 was the session, probably I can say, that was having more of the one-liners. When this COVID came, post-COVID, things have changed drastically, right? No more these FMG examinations are those one-liners which you'll just highlight and you will just see the option in the questions and you'll mark it. Okay, things have changed. They're pretty changed since then, and all of you should be well prepared from the clinical perspective, right? So orthopedics, I can tell you, is one of the easiest subject, right? And it is that subject where you can score all the 100% questions right. Whether you're going to get some 5 questions or 10 questions or 15 questions hardly matters, but you can easily mark all of them absolutely right. Not only that, when you go ahead very properly with the orthopedics, the base of orthopedics is always in anatomy, right? Majority of the questions of your anatomy, whether it is from upper limb, whether it is from lower limb, they usually are a part of your orthopedics itself. So whenever we are reading orthopedics, we always make sure to learn some of the anatomy part as well, isn't it? So see, it is not always an individual subject. It has to be something like integration of all the subjects which are relevant to each other. So now when you talk about orthopedics, part of radiology also gets covered, part of anatomy also gets covered, part of medicine also gets covered. So questions will be from various subjects, right? So let's start the day. And today I'm going to start with you 24 paper we have discussed, 23 paper we have discussed, and now I'm on to the June 2022 paper, right? So till December we have discussed for the session of 2022, and now here we have the questions coming up from your the session. I can keep it like this so that you all can see it easily. Just give me one moment again. Yeah, now I think it is better. Make it a little more closer so that it is further okay for all of you. So now have a look on this. Yeah, so we can go like this. Okay, so I think it is little better now. This should be fine. Okay, so let's start with the questions of your FMG June 22. So in the June 22, we had certain questions, the memory-based recalls, right? So young individual, tell me the answer for this. Young individual arriving in the emergency department complaining of pain and swelling in their right knee, right? Upon examination, a plain radiograph revealed the following result. What is the effective course of treatment for this specific condition? Now, what is the diagnosis you all can make out here? What is the diagnosis? If you look at this particular X-ray, you all can easily make out that it is a fracture. It is basically a fracture of the patella, right? The fracture of patella. And what kind of fracture it is in the patella? In patella, you all can appreciate or if with TBW. Absolutely right. So first of all, see, every time you should always be looking at the X-ray very, very carefully. Don't just look at the patella. This is a very, very important message I'm giving to all of you. Very important message. See, in this particular case, when you look at this, the diagnosis goes in favor of the two-part displaced fracture patella. Two-part fracture patella, which is showing you a displacement already. Be very, very careful about this particular, question. So it is two-part fracture of, what happened? Something went wrong. Just give me a moment. Something is wrong. Oh, it got disconnected. All right. So two-part fracture of patella, which is actually displaced, right? So this displacement is the word which is going to change your answer, right? In your exam, if you get a question like this, can see the questions? Okay, thank you. So now when you know this is the patella is a sesamoid bone in the tendon of the muscle quadriceps, right? Whenever it is already displaced like this, then yes, you are right. The answer goes in favor of tension band wiring. What if they give you a injury where the patella is showing you a fracture line, right? Patella is showing you a fracture line, but it is still undisplaced, right? So see the question very, very carefully. In that case, the answer will change to cylindrical cast, right? So anytime you see a fracture which is undisplaced, we go for cylindrical cast. Anytime it is a fracture which is displaced, then we go for the tension band wiring, or what you are calling as ORIF with the tension band wiring, right? So be very careful. Patella doesn't mean always TBW. It doesn't mean TBW. It means that it has to be a fracture which you cannot manage conservatively. Patella, if it is undisplaced, it doesn't require a surgery, right? Be very, very clear with that part. Now, what is second one? What is the probable diagnosis of a 30-year-old male who has been experiencing a slowly increasing swelling near his wrist joint for the past 3 months, as depicted in the provided image and X-ray film? What do you say? What do you say? Now, please follow the rule we have discussed yesterday. I have told you the rule yesterday, no? This was the rule we have discussed yesterday, that whenever you are talking about the tumors, you have to follow 3 steps, right? Step 1, step 2, step 3. This is what we are supposed to follow, isn't it? So follow the 3 steps and try to figure out what can be the possible diagnosis. What can be the possible diagnosis? Just try to figure out GCT, okay? So step 1 has to be location, step 2 has to be nature, step 3 has to be special feature, right? So osteoclastoma. So when you look at this particular image, you can easily make out what is the location over here. When you look at the location, it is epiphyseal, right? When you look at the nature, you can see there is some irregularity over here on the ulnar margin, right? This is actually showing you some little aggression. And we know that giant cell tumors are locally aggressive tumors, right? They are locally aggressive tumors. And what you can see inside are small septations, right? These are all the septations that you can see. So giving it a soap bubble appearance. So yes, the answer is right. It is osteoclastoma. It has to be giant cell tumor, right? The osteoclasts are the giant cell tumor. Perfect. You're absolutely right. Okay. Then we have the next one. A 6-month-old child is brought to the OPD with the deformity as shown in the image below. Which of the following is your line of management? See, the child is already 6 months and he's being brought in the OPD. So they're asking you what is the line of your management. So let's see what is the image they're providing you. So image they are showing you is basically the CTV, right? You all can make out. It is CTV. And what is the primary management for any child when they are presenting to you with the CTV? They are not saying the child is a grown-up kid who is already walking. Child is 6 months old, right? So any newborn baby being brought to you, what should be the plan? What do you suggest? We have got 4 options. Yeah, CTV, absolutely right. It is CTV. So what is the plan for these kind of kids? So what you will do, manipulation casting, PMSTR, triple arthrodesis, advanced procedures. So should we go for a surgical one or should we go for a conservative one? What do you say? A surgical one or a conservative one? What do you say? A, you want to go for the manipulation and the casting. Absolutely right. See, CTV, whenever you are dividing the CTV into its variable types, okay, whenever you divide the CTV into its variable types, always remember, see CTV, it can be a primary CTV or it can be a secondary CTV, right? Primary or the secondary CTV. Now, either it is a case of a primary CTV or whether it is a case of a secondary CTV, you should always remember that the primary management always starts with the conservative plan, right? It is always a conservative plan, whether it is a primary one or CTV, secondary CTV, right? In both of them, our primary management has to be the conservative management. All right, never forget that. Okay, surgeries are indicated when the child has broadly crossed more than 2, 3, or 4 years, when it's a neglected case or it's a defaulter or a failure kind of patient. Okay, so always remember conservative management has to be the ideology here. Now tell me, in CTV, when you talk about the CTV, when you have to correct the deformities, what should be the order of correction? In CTV, what should be the order of correction? What do you say? So order of correction in CTV. What should I write down? What should I plan? How should we plan for the CTV management? So order of correction in CTV. What do you say? Order of correction in CTV. What do you say? How are we supposed to plan the management? So primary management always is conservative, right? So what are the steps of correction? Always remember one very basic thing which I have seen in most of the student getting confused is whether the plaster should be below knee or above knee. Always remember, bachcho, that plaster application, always follows the same principle, that plaster has to be applied above knee, right? Above knee cast has to be given in the management of CTV also. Why? Basic principle is same, no? That it is when you are putting a plaster, you have to block a joint above and the joint below. And you all should remember at what joint, what deformity is happening, right? So ankle joint is giving you equinus. That means ankle is already the deformed joint. Now, if you just look at the deformities, I'll just mention the deformities on one side, right? I'll just mention the deformities here. See, when we are talking about the deformities, when you are talking about deformities, what all can be the deformities here? When you are mentioning the deformities which are seen in CTV, see, number one, don't forget these are very, very important. At the forefoot, which deformity can be seen at forefoot? At forefoot, what we can look at is adduction. At forefoot, what we can look at is adduction, number one, right? Number two, when you look at the midfoot, what is the deformity in CTV at midfoot? CTV is giving us the cavus, right? When you look at the hindfoot, what is the deformity which can be seen at the hindfoot? In the hindfoot, the deformity which can be seen is varus, when the calcaneum is deviating medially. And fourth, at the ankle, what is the deformity that can be seen? It is equinus, right? It is equinus. So adduction, cavus, varus, equinus, these are the deformities which are seen in CTV, right? So ankle is the joint which is getting involved, right? Ankle is the joint which is getting involved. So the basic principle of plaster application, that we have to go for blocking of the joint above and the blocking of the joint below. And that is why the basic principle goes as the above knee casting, right? These four are very, very important. You should always know which deformity is occurring at what part of the foot in CTV, right? So when you looking at the deformity, these are the ones. Second, how do we correct the foot of CTV? Always give the above knee cast. And what is the order of correction? Order of correction has to be cave. So CAVE, cave. And what is this method that we are using? What is this method called as? This method we are talking about is Ponseti technique, right? This is Ponseti technique. So when would you like to start the management of the child? Start the treatment as soon as possible. There should be no delays, right? Start treatment as soon as possible. There should be no delays, right? No delays. So given an opportunity, the first window you get, first opportunity you get, you start the treatment. We don't wait, right? So above knee cast, cavus, adduction, varus, equinus. These are the four steps in which we correct the deformity, right? So please remember, when we are correcting the CTV, foot by this cave method, by giving the plasters, how with every plaster you will come to know that patient's foot is getting corrected. There is a scoring system which we keep on assessing with every plaster to know about the correction of the foot, whether the foot is getting corrected or not getting corrected, right? You have not understood the significance of involving knee in the treatment. Beta, plaster application, what is the basic principle of plaster application? Immobilization, right? How many joints are to be immobilized? A joint above and a joint below, right? A joint above and a joint below. Now ankle, we have just talked about this. Ankle is the involved joint, right? Ankle is getting involved. That means a joint above is which one? Knee joint. And that is why we have to block the knee joint also. Tibia is a part of deformity. So we have to block the whole tibia. So we give a above knee cast. Is it fine? The graffiti mind. Is it fine with you now? Okay. So I hope this is clear. Now this above knee cast, cave is the sequence of correction. Ponsity is the method. And we start the treatment as soon as possible and we never delay. Right? Normally, in 6 to 7 plasters, you should be able to treat the patient. 6 to 7 plasters should be enough to treat the patient, right? Not more than 10 in any situation. Not more than 10 in any condition. You are going wrong, right? If it is more than 10, you are going wrong, right? Number 6, once you correct the foot, how to maintain the correction? Maintenance is done by the splints. And what is that splint called as? The Dennis Brown splint, right? That splint is called as the Dennis Brown splint, and you all should know the image of Dennis Brown splint. The Dennis Brown splint will be two shoes connected to each other by a bar, right? Two shoes connected to each other by a bar, right? Always remember the shoe, two shoes connected by a bar. And when the child is walking, if required, we go for the CTV shoes, right? You should know the CTV shoes with the features as well. Right, the lateral margin of the CTV shoe, lateral margin is always raised, right? Lateral margin of the shoe is always raised to counter which deformity? To counter the deformity of inversion, right? To counter the deformity of inversion, because when all these 4 deformity combine that we have written over here, the foot goes in the state of inversion, right? These all 4 will make the foot go in the state of inversion. And where does the inversion happens? Please remember, this occurs at the subtalar joint, right? Inversion is going to occur at the subtalar joint, right? Inversion occurs at subtalar joint, all right? So lateral margin is raised and that will be countering the inversion. Okay, now second, the medial margin of the shoe. The medial margin of the shoe, it is kept straight. Medial margin is kept straight, right? It is kept straight. Why? Medial margin is kept straight to counter the deformity of the adduction, and secondarily there is a cavus on the medial side, right? And then we have the heel concept, right? There should be no heel to counter what? To counter the deformity of equinus, right? These all pointers you all should remember for the management of CTV. There should be no mistake in this, right? Order of correction, the deformities, the joint where they are happening, these all are your MCQs, right? These all are your MCQs, nothing to be missed from here, all right? So is this fine now? The order of correction in CTV, is this fine? You all are clear with this? So no point from the CTV should be missed. No point should be missed from here, and this is a complete detail of CTV. This image, if you want, I'll be putting in my story as well. I'll take a click and I'll just post it in my story as well. Okay, so you can just make a note. I'll share in the orthopedic group as well, so you can download from there. I hope this CTV point is fine. Very nice. All right, let's go next one. Let's go next one. So next one you have, what is the most probable diagnosis for a 34-year, what is the most probable diagnosis of a 34-year-old male who has been experiencing worsening lower backache and stiffness in the morning? Now this is a key, right? A young male, 34, right? 34 with a backache, okay? And the most important clue, the key word here is stiffness in the morning, right? The morning stiffness, yes, it gives you the clue. His symptoms improve with exercise. So pain is more after rest, right? The pain is more after the period of rest. And that is a classical one for any inflammatory arthritis, right? And you know that the arthritis which affect the young male, backache, morning stiffness is nothing else other than ankylosing spondylitis, right? And that comes to you with what kind of feature? The X-ray, you can see the sacroiliac joint, it is already fused. Sacroiliac joint is already fused and the spine is able to show you prominences. What is that called as? This all fusion of the spine. This is all called as the bamboo spine. And these shining spinous processes, you all can make out this one. These are called as dagger sign. So we have a dagger sign. We have a dagger sign as well as we have this bamboo spine. Yes, you're right. You are absolutely right. Right? The bamboo spine or the dagger sign. Okay. Now, one other important point which I want you to recall, remember always. See, this is true. Most of the time the question is given like this. A simple history, young boy, backache, and a young person with backache which is improving after the period of activity. which is more after rest, this is classical for AS. Sometimes you might have a mention of enthesitis, right? Please be watchful for the language of the question. They may sometime mention to you of enthesitis. Now, what is that enthesitis? Enthesitis will be that there is mention of insertional areas of the tendon getting inflamed. For example, they may mention of plantar fasciitis. Patient is having pain in his heel when he is getting up in the morning. Plantar fasciitis, right? Patient is suffering from again and again Achilles tendinitis. Patient is having tennis elbow. Patient is having golfer's elbow, like that. So enthesitis is an associated feature. So there might be a mention of enthesitis sometime in your exam as well, right? So be very, very watchful about enthesitis. So yes, this is bamboo spine and the dagger sign. Absolutely right. Okay. Next one, if you can figure out, based on the image provided, what possible diagnosis can be determined? Based on the provided image, they want you to diagnose something based on image only. Now see, when you look at the spine, when you look at the vertebra, what you can make out here is the vertebral body here, this level is destroyed, right? The vertebral level is destroyed, okay? The vertebra itself is destroyed. Now in vertebra, if there is a destruction specifically involving the intervertebral disc space, right, then that goes in favor of the tuberculosis, right? That goes in favor of tuberculosis, POTS, right? So what is the first or the most commonest pattern of involvement? The most commonest pattern of involvement is paradiscal, right? Most commonest pattern of involvement is paradiscal. And when it is paradiscal, it is not fish mouth, beta. Fish mouth will be when the vertebral body, they get depressed like this, right? That will be the codfish spine appearance. But for that, they have to get a depression at every level, right? They have to get a depression at every level. That will be fish mouth. And please don't get confused ever. Right? So this osteoporotic change will be very much, visible to you very, very properly, right? Now this is not fish mouth. When there is a destruction of the vertebral body, most likely it is an infection. And the most commonest infection of the spine is tuberculosis, right? So it is most likely a case of tuberculosis. This one is most likely a case of pot spine. Though it can be a case of some malignancy also, metastasis also. But then please remember that Mets, malignancies, all of them, they don't get into the discal areas. Disc usually is, preserved in the metastatic lesions, right? That should be very, very clear to you. All right. Fish mouth, graffiti mind, no confusions here. Okay. Don't just get confused. All right. That's a very interesting one. If you can figure out, what is the possible diagnosis for a 77-year-old male who visited the clinic due to deteriorating hip and back pain along the symptoms of weight loss and elevated PSAs? What do you say? What is the probable diagnosis for this patient who is coming to you with the deteriorating back pain, hip pain, and weight loss, appetite loss is there, elevated PSA level, right? So PSA, is for prostate. They are raised and the bone doesn't seems to be of the right density. They seem to be, too white in the density. Okay, so too white in density is suggestive of what? Too white in density is suggestive of what? That might be some blastic kind of, lesion. So there might be some blastic kind of Mets, which might be the possibility, right? So PSA, the prostate. The PSA is the prostate one, right? So prostate, is usually producing plastic kind of Mets, right? So this might be a case of metastasis because of the prostate carcinoma. Prostate carcinoma usually produces a blastic secondary. On the other hand, the breast carcinomas, they usually produce a lytic one, right? It is a usual one. I'm not saying always lytic. It is a usual one, which is going to produce the blastic one or the lytic one. So prostate blastic, breast carcinomas usually lytic, right? Purely lytic usually we say is in association with the renal and thyroid metastasis. Renal and thyroid metastasis usually are giving you the lytic kind of lesions, right? So all white. So every word is going to, matter in your exam. Every single word is going to matter. So be very, very clear and be very focused upon what are the keywords in my questionnaire, right? Whatever is the question, read it carefully and try to figure out the keywords. 77, right? Deteriorating multiple bone pains, back pain, hip pain, right? along with constitutional symptoms like weight loss, loss of appetite. So maybe some sort of metastasis is happening. Some sort of spread to the bone is happening, right? And blastic one, all white they are giving you to tell you it is most likely a prostate one. All right, this is fine, I hope. So this should not be mixed. Yeah, this is a very interesting one and a very high probability of being asked in your upcoming exam as well, right? So this patient came with back pain. Image is given below, right? What is the diagnosis? Can somebody say diagnosis here? Can somebody say diagnosis and the level also, if you can make out? What should be the level and what should be the diagnosis, if you can make out? Yeah. Come on. A. Oh, A. Listhesis you are saying. Okay. So it is listhesis. What level? Level you have not mentioned. What level it is? See, this is sacrum. This is sacrum. So this is your sacral area, right? And this is your lumbar 5. So L5S1, right? Now please tell me in L5 and S1, this is the listhesis level. You all can make out? Yeah, very good. It is a L5 which has got a listhesis over the sacral 1 vertebra, right? At this particular level, please tell me which should be the most commonest nerve root to get involved. If they ask you that which should be the most commonest nerve root to get involved at this particular level, L5 and S1, the sacrum, which should be the root? Should it be L5 root? Should it be S1 root? Should it be L4 root? Which root should be the commonest one to get involved over here? Which root should be the commonest one to get involved over here? What do you say? L5, S1, which one should be the commonest nerve root? Now this is a very high probability. L5, no. This will always be the most commonest we are saying, right? L5 can be involved. I'm not saying that it cannot be, but more commoner will be S1. Always remember whatever level has been marked, L5, S1. So it is always the lower root which is usually involved, right? S1 will be the more commoner. When you are talking about the L4, L5 level, when you are talking about the L4, L5 level, here the most commonest root to get entrapped between L4 and L5, it is going to be L5, right? Same way, when you talk of L3 and L4, it has to be L4, right? Got that point? Don't forget this out. Don't forget this one. This is going to be an important one and it has been asked in your recently conducted INSET examination also, which was a repeat question. And again, you can too have this question, right? Straightforward question. They marked this area and they asked which nerve root is involved at this particular level. What is behind vertebra? These, beta, this is a cross section, no, sagittal section of the spine. So the spinal canal is not visible to you here. This is the spinal cord region, the spinal canal region, and these are all the spinous processes on the back. Okay, so taking a sagittal section like this from the vertebrae, that is how it is looking like. Okay, so that is the listhesis, absolutely correct. Let's see another one. A patient met with RTA and had a fracture of the shaft of humerus. Oh, very, very important one again. A patient met with RTA and had a fracture of the shaft of the humerus. After injury, he is not able to dorsiflex his wrist. Wrist movement is not happening, right? Wrist is not working. He was advised to have a splint as shown in the figure. First of all, tell me which nerve is involved here. Right? Which nerve is involved here? If dorsiflexion of wrist is not happening, so which nerve should be involved here? What do you say? Which nerve should be involved here? So nerve involved is radial. Very good. And for the radial nerve, you know that it is going to be a wrist drop. It is going to be a finger drop. So what kind of splint is this? This is which kind of splint? What do you say? Radial nerve is fine. Absolutely right. So which kind of splint is this? Radial, yes, it is radial. So which splint this one? Come on. What should I call it? Cock-up splint. Very good. This is a cock-up splint. Now see, any splint that we are using, they are of two types, right? Either the splint can be a dynamic one or the splint can be a static one. Can you figure out this given splint is a dynamic one or a static one? It is a dynamic one or a static one. What do you say? When the splint allows you any mobility, right? When the splint allows you any mobility, right? Then it is dynamic. When it is just a, supporting kind of structure over here, then it is going to be static, right? So this one is a static one. Okay. Where do we use the knuckle bender splint? In which condition should we be using this knuckle bender splint? Knuckle bender is used in which conditions? What do you say? Knuckle bender will be used in which conditions? Come on. Knuckle bender will be used in which condition? So these are used for claw hand, right? When you bend the knuckles to get the length for the ulnar nerve injury, right? So for claw hand. Thomas splint. Where do we use Thomas splint? Where do we use Thomas splint? Thomas splint is used to stabilize the patient during transportation or management during the fracture shaft of the femur, right? Some knee injury, some shaft of femur injury, we have to use Thomas. And where do we use this aeroplane splint? Aeroplane is used for brachial plexus injury, right? It is used for the brachial plexus injury, right? That will be used for brachial plexus injury. Scoliosis, which one? Scoliosis के लिए which brace do we use? Oh, गड़बड़ हो गया है तो. Scoliosis के लिए we are using, when you are saying scoliosis, right? When you are saying scoliosis, we are using Milwaukee, right? We are using Milwaukee. Okay, for scoliosis in a child, it will be Milwaukee. So brachial plexus injury, it is aeroplane, right? All right. So this is fine. Taylor's. Taylor's is for, not for scoliosis, beta. Taylor is also not for scoliosis. Taylor is basically to block the dorsolateral spine, right? When you want to block somebody's dorsolateral spine, okay? Taylor's, let me just show you. Wait. Now, ये तो बहुत सारा गड़बड़ हो जाएगा ऐसे. Okay, so let me just show you something here. देखो, अलग-अलग तरह के splints you should know. This one, look at this. This is called Taylor's brace, right? This is Taylor's brace. This one is Milwaukee, right? Taylor's and Milwaukee. Taylor is used when you want to block this dorsolateral spine. See, dorsolateral, these are the belts over here with the strips inside. So this will not allow the patient to bend forward. This is dorsolateral immobilization. This is Milwaukee, right? This one is what you call aeroplane splint for brachial plexus injury, right? And this one is Thomas. See, this first one is Thomas. It is used to stabilize the fracture of the shaft of the femur, right? I hope these all four are fine. No mistakes in this. These all four should be very, very accurately, identified, right? So this is about a different kind of splint. Splints you all should know, right? Splint you all should be very, very clear and aware about them, right? Now, this is a congenital anomaly, maybe sometime asked to you. So you can see that, multiple fingers are not there, but two fingers are stick to each other. There is no bifurcation raphe which has occurred here, right? So this is simply called a syndactyly. When it is occurring together, it is syndactyly, right? That is a anatomical abnormality here. So nothing very special. Yeah. Another very, very important question. What is the fracture of the pelvis? What is the fracture of the pelvis given? What do you say? What is the fracture of the book? Open book? No. See, upper ramus, lower ramus of both the side is breached. Upper ramus, lower ramus of both the side is breached. So what exactly is this? Both the side. Bilaterally, both the pubic rami are involved. So what is that called as? This is called open book. No, this is called straddle. Open book is when the pelvis opens anteriorly from here, right? Pelvis is going to have a posterior column intact and anteriorly the pelvis opens like this. That is going to be an open book, right? Straddle is bilaterally both the pubic rami. Bilaterally both the pubic rami, right? Okay, so that is bilaterally both the pubic rami. That is called as the straddle fracture. Open book is when the pelvis opens anteriorly. And this fifth question, I expect you all to answer very accurately. We had discussed about I have shown you a table of the attitudes of the hip, in which condition, what kind of attitude can be seen. Can you answer this? A person sitting on the front seat of the car met with RTA. Following injury, his lower limb is in adduction and internal rotation. In adduction and internal rotation, right? RTA, front seat, attitude, adduction, internal rotation. What is this pointing towards? I have not even seen the options, but can you make out? What is this pointing towards? The front seat of the car and the flexion, adduction, internal rotation is the attitude. Can you make out? Can you make out? X-ray will see. Faber-Feder. Okay. Dashboard. Yes, very good. So it is pointing towards dashboard, and dashboard injury. Dashboard injury is pointing towards what dislocation? Very good. It is posterior dislocation, right? This is going to be posterior. Though in this particular X-ray, I don't see any kind of, dislocation. Ignore that. So this is posterior dislocation of the hip. Very, very good, right? See, whenever you are trying to, I don't have any video or image to show you, like, okay, I'll just try to just draw some rough sketch to explain to you the internal rotation, external rotation. See, understand. When the patient, let's suppose, is lying here, right? Patient is lying here and we are trying to manipulate the limb. See, when we have to talk about the hip joints here, right? We have to talk about the hip joint. What we do in the hip, we take the legs, like if this is femur, let's suppose, this is femur we have. So in femur, please know that below femur, this tibia, when you're moving this leg, when you move this leg internally, right? Leg, I'll have to better, it will better if I okay, what I'll do, Faber and Feder, I understand. This is not a very simple thing to be shown on pictures here. Okay, so just give me today's time. Today I'll make a video and I'll post it on this as a post only, right? Faber and Feder, this I'll be teaching you. That you want to know that how the movements happen. That is what you want to know. How the movements are seen. Alok and who else mentioned this? Faber and Feder. So it was Alok only. Alok, you want to know that how these movements are done? So I'll make a video today and I'll share it with you today itself, right? Just have a watch and I'll make the video, right? So always remember, in the anterior dislocation, it has to be your abduction and external rotation. Abduction will have the limb lengthening, right? So lengthening means the femur will be coming down, right? It comes down. So abduction means anterior and down. And this posterior dislocation comes with adduction and shortening, right? This shortening will make the hip go up. Okay, so posterior dislocation, adduction. Flexure neck of femur and the shaft of femur, they too will have the rotations, right? But flexure neck femur will have less than 45 degrees of rotation and less than 1 inch of shortening because they are intracapsular injuries, right? So don't forget this hip table. I hope everybody is having that differentials, that in which condition the patient comes to you with what kind of pathology. If not, that is a table I can make with you tomorrow morning, right? Tomorrow I'll not be able to take the session. I'll be taking it day after tomorrow, right? So tomorrow is not possible. So this table everybody should be having. Please go through that table, in which condition is abduction, which condition is adduction, like that. Please go through it very properly, right? Go through it very properly. Now this answer I'm expecting from you again from the shoulder table. This answer I'm expecting from you, the shoulder table. What do you say? What should be the answer for this? Patient diagnosed with supraspinatus tendinitis. If there is supraspinatus tendinitis, what is the diagnosis? What is the diagnosis? What do you say? If there is supraspinatus tendinitis, what is the diagnosis? What do you say? Come on. This has to come from your side. This has to come from your side. Please tell me what should be the answer for this one. It is B. B means 15 to 90 degrees of shoulder abduction. No, that is wrong. Absolutely wrong. Absolutely wrong. Supraspinatus, why it is going to have a problem, a defect between 15 to 90? Supraspinatus, why it should be having that problem? Think more. They're giving you a clue. Supraspinatus tendinitis. Supraspinatus tendinitis. Think over it. What is the diagnosis? A, 16 to 120 degrees of abduction. What is the diagnosis here? What is the diagnosis here? What do you say? Diagnosis, if you can make out. Diagnosis, if you can say. 0 to 15, no. Absolutely no. 0 to 15 is the job of supraspinatus. 0 to 15 is the job of supraspinatus. Painful arc, very good. Supraspinatus tendinitis they are mentioning, no? Tendinitis means painful arc syndrome. Patient is going to have the pain during mid-range of abduction, right? Patient is going to have pain during mid-range of abduction, and mid-range is 60 to 120. When, if they would have been mentioning that supraspinatus is having a complete tear, right? It is completely torn, then there is no movement at all from 0 to 15, right? Complete tear means no movement, no initiation of abduction. Beyond 15 they can do. 15 to 90, this one is the job of deltoid, right? This one is the function of deltoid. So it has got nothing to do with the supraspinatus part, right? So next one is the physiology one. You must have read about this. All right. So guys, these were the questions of this particular 2 sessions or 3 sessions we have discussed, right? So now the homework for you. Now what I can realize is some of you are having this trouble with the movement of the hip joint, number one. Second is you all should be aware about in which condition of the shoulder and in which condition of the hip the patient presents with a particular attitude, right? And these are two tables, two notes which we always make in the class also, that when in which condition the patient is going to present to you with what attitude, abduction or adduction or internal rotation or external rotation, maybe sometime a mismatch, right? Please go through it. If you have not been in my class or my workbook is not there with you, please try to figure out and let me just drop me a message tomorrow or day after, whenever I'm going to take a session, we can make. And I believe that I have already made this one table with you. One we made, I think, in this session only. So if it is not with you, I can make one with you in the upcoming sessions. Shoulder pathologies, cast splint, I'll take a separate session on the cast and the splints. I'll take that. All right, I'll take that. So yeah, I'll take that for sure. Okay. So now cast and splint is on my side. I'll take a session on the cast and the splints and maybe the traction systems also. And these two, the shoulder and the hip, definitely they are very, very important. All right. I hope now preparation for everyone, whether you are going for the FMG exam on 17th of January, whether you're going for NEET exam, preparations are going fine. Gradually at all the places, the batches will be ending. Maybe some 3 classes, 4 classes will be pending and you will be, completing your curriculum. So for all of you, a simple suggestion. If you're going for FMG, the course by this time should have been done and you must be on your revisions, right? That is for sure. And if you are, lacking in some subject, I got few of the messages from the student that some of my subjects are pending. Should I go for rapid revision? Should I go for this or that or something like that, shortcuts. But see, if multiple subjects are left, then we have to formulate a different strategy for you. But if your 1 or 2 subjects are done, definitely it's a good idea to go with the rapid revision, but make sure you have some handwritten notes with you. Second important thing, all of you should start giving the grand test, right? It is very much required, very much mandatory. Start giving the grand test, and giving grand test is again going to be your one step only. You have to improvise on that. Whenever you are giving the grand test, make sure that you are reviewing your grand test very, very properly, right? Review is very important. In the review, make sure that you just keep on marking which subject you are lacking in, right? And whatever subject you are not doing well, please review that subject. Don't run away from a subject. Don't try to have a shortcut to the things that I'll learn the pyqs and it is going to work. No, pyqs don't work. pyts work. That is why with my questions also, I am trying to give you the explanations of all the questions as much as possible, right? So pyt will work. pyqs usually don't work, right? Nowadays, things are clinically being asked, in the clinical pattern are being asked. So you should be very, very clear about how my patient is going to come to me, right? So rather than being focused on theory, we should be more focused on the practicals, the clinical part. All right. So see you again in another session. This was day 3, session 3. And gradually, once orthopedic is done, I'll take up the questions of my relevant sections of anatomy, my relevant part of surgery as well, whatever comes, medicine as well, whatever comes in my part, right? So, okay, so if we have revised notes at least 2 times and can recall 70-80%, will it be enough? Beta, देखो, पढ़ना एक अच्छी बात है, nothing wrong in that, right? पढ़ना एक अच्छी बात है, कुछ भी गलत नहीं है उसमें. Hi, good morning, ma'am. So, see, पढ़ने के अलावा we should know that we are preparing for an exam. Theory exam तो है नहीं ना हमारा कि हमने पढ़ लिया तो theory answer लिख देंगे. हमारा exam is a MCQ based exam. And we should be able to analyze all our theory very, very well. And we should know that am I able to, deliver my theory in my MCQs. आपने पढ़ाई कर ली, बहुत अच्छी बात है. 2 बार रिवीजन कर लिया, बहुत अच्छी बात है. पर अगर आपने टेस्ट ही नहीं दिए और टेस्ट देने के बाद अपनी गलतियों को नहीं इंप्रूव किया, सो वो गलती फिर हम एग्जाम में करेंगे. सो वाई शुड वी बी वेटिंग फॉर दैट डे? वी शुड गिव टेस्ट नाउ एंड एज मेनी एज टेस्ट यू कैन गिव. सो टेस्ट को दो, टेस्ट देने के बाद रिव्यू करो कि कौन से सब्जेक्ट में गलत कर रहे हो एंड उस सब्जेक्ट को फिर से अपनी वर्कबुक से पढ़ो, राइट? डोंट कीप ऑन बुक मार्किंग, राइट? सो डोंट कीप ऑन बुक मार्किंग इन योर ऐप. बुक मार्क करने से बाद में क्या होगा? इट इज गोइंग टू प्रोड्यूस लॉट ऑफ स्ट्रेस एंड कंफ्यूजन फॉर यू कि अब मैं बुक मार्क रिवाइज करूं कि अपने वर्कबुक को रिवाइज करूं, right? So जब भी आप कोई GT देते हो, the best idea is always to review from your own notes. अपने notes से revise करो. It is going to help you like anything, right? तो इसको follow करो and let's stay connected, right? So whether you're going for NEET exam or the FMG exam, we'll be there with you, right? Stay focused and stay consistent. That is the whole idea, right? Consistency wins the game always, right? It is a consistency that wins the game always. All right. So just do this. All right. So ma'am has dropped a message. You will take the session tomorrow. Ma'am, tomorrow I'll not be taking a session. So I'll be traveling that time. So I'll not be able to take a session tomorrow. You can start the session. So OBGY session we are going to have tomorrow, bachon, on the Insta, right? So we'll keep you posted whether it is at 6 a.m. or 6:30 a.m. So we'll keep you posted, right? So tomorrow we are going to have the morning 5 a.m. sessions. Your mentor duo will try to do the best we can do for you, right? And आप लोगों से भी just we expect this much that you just stay consistent, stay focused, don't feel low, right? And thoughts will keep on coming and going. But what we are supposed to do is to work on our lower part or the negative part, right? Keep working on that and things will improve for sure. All right. So yeah, so ma'am will be taking the session tomorrow. Okay. So I'll not be available tomorrow morning. So day after, definitely let's meet again. All right. So let's stay connected, keep working together, and let's work for the day we have been like waiting for the last 4 years, 5 years, 6 years, and the day is just very, very near now. So all the very best. Have a wonderful day ahead. Keep studying and just stay on that track. All right. That is all from my side for today. All right. Have a wonderful day. Thank you so much, everyone.